Hey there, everyone. Welcome back. I hope you enjoyed your spring break if you're just coming back from spring break. Hi, how are you? All right. So today we're talking about the basal ganglia, and this is going to be covering chapter 16 from our textbook, and that is Neuroscience Fundamentals for Rehabilitation by Lori Lundy-Ekman. Okay, so today we're talking about the basal ganglia. And that is one of the most important systems in our brain for understanding movement, but it's also one of the easiest to oversimplify. It's actually very complicated. The basal ganglia are not purely just a movement center, they also help predict the effects of possible actions. They help us to select appropriate actions, suppress unwanted ones, and then they help to carry out a final motor plan. They also contribute to attention, emotion, motivation, social behavior, and also our eye movements. So, when this system goes wrong, the result is not just a motor problem. It can actually affect behavior, cognition, and daily function in a really big way. So, by the end of this episode, you should be able to identify the nuclei that make up the basal ganglia, explain the major non motor and motor circuits, describe the hyperdirect go and no go pathways, and connect all of that now to disorders like Parkinson's disease, Huntington's disease, dystonia, Tourette's disorder, and dyskinetic cerebral palsy. All right, let's start with the anatomy here. So, the basal ganglia include the caudate, putamen, globus pallidus, subthalamic nucleus, and the substantia nigra. Those are our five basal ganglia. The caudate is that C-shaped structure in the cerebrum. The putamen and globus pallidus are also in the cerebrum. And the subthalamic nucleus, or STN, is in the diencephalon. And the substantia nigra is in the midbrain. So we had three in the cerebrum, one in the diencephalon, and one in the midbrain. Now, the word basal here in basal ganglia refers to the fact that these nuclei are located in or near the base of the cerebral hemispheres. So they're very deep central brain in their anatomical location. So if you were looking at classic diagrams or drawings here, you'd see the caudate wrapping around the thalamus, with the head of the caudate anterior to the thalamus, the body superior to it, and the tail then curving posterolaterally and then inferolaterally around the thalamus. The putamen now sits more laterally, and the globus pallidus lies medial to the putamen. The subthalamic nucleus sits inferior to the thalamus, and the substantia nigra is down in the midbrain. If you were to look at our slides or in the textbook, you could see that there's a figure that also includes the red nucleus in the images. And that here is just an anatomical landmark that we might mention a few times. But I want to remind you that it is not part of the basal ganglia. There are also a few joint names you need to know, and this is where it may get a little confusing. But remember, we have five core basal ganglia, but sometimes names are used to identify the combination of a couple of them. So the first name I want to bring up is the lentiform nucleus. The lentiform nucleus refers to the globus pallidus plus the putamen together. So remember, the globus pallidus and the putamen are individual basal ganglia. We use the term lentiform nucleus to just group them together. Next, we have the striatum, which refers to the caudate plus the putamen. And the ventral striatum is now the junction of the caudate and the putamen. So we had striatum, which is the caudate plus the putamen. The ventral striatum, which refers to that specific junction where the caudate and putamen touch. And then remember, we also had the lentiform nucleus, which is the globus pallidus plus the putamen. Now, functionally, one detail that matters a lot is that the output nuclei of the basal ganglia are the globus pallidus internus, or the internal globus pallidus, and the substantia nigra reticularis. These are the two output nuclei of the basal ganglia. Now let's talk chemistry, because the basal ganglia are really a story of carefully balanced excitation and inhibition. This is why we harp so much on what's happening at that tiny little microscopic level in chapters like 5 and 6. It's coming back to haunt you now, because we need to understand excitation and inhibition to understand how the basal ganglia work together. So cortical motor areas excite the striatum. Remember, what is that striatum again? It is the caudate plus the putamen. So we're talking about the striatum. Cortical motor areas excite the striatum using, drum roll please, glutamate, the primary excitatory neurotransmitter in the central nervous system. So the cortical motor areas excite the striatum using glutamate. Dopamine, which is produced from the substantia nigra, projects to the striatum, and it adjusts the signals that are moving through the system. Then the output nuclei provide the just right amount of inhibition on their targets. So the main neurotransmitters to keep in mind here are glutamate, which is excitatory, GABA, which is inhibitory, and now we also have dopamine coming into play. And I want you to think of dopamine as being modulatory. It's used to fine-tune those excitatory or inhibitory signals. So before we get into something called the motor circuit, it helps to appreciate that the basal ganglia also participate in several non-motor cortical basal ganglia thalamic circuits. So when we think of the basal ganglia, we tend to think of motor control and things like Parkinson's disease. But it's important to remember that there are also cognitive and other non-motor effects of the basal ganglia circuits. First, we have the goal-directed behavior circuit. So the head of the caudate participates in decision-making related to goal-directed behavior. It helps to evaluate information for perceptual decisions, planning, and choosing actions in context. Importantly, this circuit is not controlling movement directly. It is instead helping decide what should be done. Second is the social behavior circuit. Again, the head of the caudate is involved, but here the role is more in recognizing social cues, regulating self-control, and distinguishing relevant from irrelevant social information. In other words, this system helps people to behave appropriately in complex social environments. Third, we have the emotion or motivation circuit, and this one involves the ventral striatum. It links emotional, cognitive, and motor systems together. It integrates emotion from the work of those other circuits, and it contributes to the perception and experience of emotion, and also has a major role in reward-seeking behavior. It's also involved in making predictions when the outcome is uncertain. So even before we talk about walking or tremor, you can already see that the basal ganglia help to organize behavior in a much broader sense. There's also an oculomotor circuit that's important to mention. The body of the caudate here participates in decisions about spatial attention and eye movements. It helps to determine whether to use rapid eye movements, which are called saccades, to direct attention toward an object. A prosaccade can move the eye toward an object, and an antisaccade can move the eye away from an object. And that requires more complex interactions, plus inhibition of the reflex to look toward the target. So there's some complex oculomotor circuitry here happening that affects that kind of reflexive eye movement. Not surprisingly, patients with basal ganglia pathology often show impaired saccadic eye movements. So you can include that in your evaluation of a person diagnosed with basal ganglia dysfunction or pathology. Now we can finally move into that motor circuit. So in kind of one summary, the basal ganglia motor circuit regulates muscle contraction, muscle force, multi-joint movement, and the sequencing of movement. The motor circuit includes the cerebral cortex motor areas, the substantia nigra compacta, the putamen, the external globus pallidus, the subthalamic nucleus, the internal globus pallidus, and the motor areas of the thalamus. A crucial idea here is that the basal ganglia profoundly affect movement, but they have no direct output to the lower motor neurons. That's important. There is no direct output from the basal ganglia to the lower motor neurons. Instead, they influence movement through other targets. For example, stimulation of the pedunculopontine nucleus, or the PPN, helps to regulate contraction of postural and girdle muscles through the lateral reticulospinal neurons. Stimulation of the mesencephalic locomotor region, or the MLR, can elicit rhythmic lower limb movements that look like running or walking. To make sense of the circuitry in the basal ganglia, you really need to understand one concept, and that is disinhibition. Disinhibition means that there are at least two inhibitory neurons in series acting on a target. So at baseline, one inhibitory neuron will suppress the target. Then another inhibitory neuron can come in to inhibit that first inhibitory neuron. The result then is that that target neuron is now freed from inhibition and becomes more active. So disinhibition is a way of facilitating activity by removing inhibition rather than directly exciting the target. So that sets us up now for the three major pathways inside the motor loop of the basal ganglia. We have the hyperdirect pathway, which is also commonly called the stop pathway. We have the go pathway, and then we have the no-go pathway. Normal movement requires function of all three of these pathways. So the hyperdirect pathway is also called the stop pathway. And what it does is it sends a strong excitatory signal from the cortex directly to the subthalamic nucleus. The subthalamic nucleus then excites the internal globus pallidus, and the internal globus pallidus then inhibits the motor thalamus. The result then is powerful inhibition of the motor thalamus and suppression of voluntary movement. It's called hyperdirect because it bypasses the external globus pallidus. So the purpose of this motor pathway is to stop movement. The go pathway, which is also called the direct pathway, facilitates desired movement. So in this pathway, we have the putamen inhibiting the internal globus pallidus. This means that the internal globus pallidus gives less inhibition now to the motor thalamus. The thalamus is then disinhibited and it can activate motor cortical areas, which activate appropriate corticospinal neurons. So the go pathway helps selected movements to actually happen. Now we have the no-go pathway, or the indirect pathway, it's also called. And this starts in different putamen cells than the go pathway, but it still starts in the putamen. The end result is suppression of unwanted movements. The putamen inhibits the globus pallidus, the external globus pallidus specifically, and then that disinhibits the subthalamic nucleus, which then excites the internal globus pallidus. The internal globus pallidus then increases inhibition to the motor thalamus, suppressing competing or unwanted motor output. So one of the easiest ways to remember the functions of these pathways is by thinking of an everyday example. Imagine that you're sitting and you're drinking water, and then you want to reach for a cookie. If you want to stop drinking water and reach for a cookie, the stop pathway then suppresses the current action. So it stops the drinking water. The go pathway helps produce the new desired reach for a cookie. And then the no-go pathway prevents any extra unwanted movements from interfering with the desired task. So dopamine here, remember that's kind of our modulatory neurotransmitter, is what helps to tune this whole system correctly. The motor circuit depends on dopamine, which is supplied by the substantia nigra compacta. Dopamine binding to D1 receptors excites the inhibitory neurons in the go pathway, which supports movement by helping inhibit the internal globus pallidus. Dopamine binding to D2 receptors inhibits neurons projecting from the putamen to the external globus pallidus, and this then shapes the no-go pathway. The net effect of normal dopamine levels is to properly adjust the tonic inhibition coming from the internal globus pallidus to then target the nuclei involved in voluntary movement, postural control, and muscle tone and gait. This is also where all internal motor processing in the basal ganglia converges, the internal globus pallidus. The balance of input reaching the internal globus pallidus determines whether a voluntary movement will occur. The internal globus pallidus tonically inhibits three major targets, and those are the motor thalamus, the pedunculopontine nucleus, and the midbrain locomotor region. In a normal nervous system, that tonic inhibition is selectively increased or decreased depending on the movement needed. Now, functionally, that means that the basal ganglia motor circuit regulates three broad activities. First, we have voluntary muscle activity through the motor thalamus and onward to the corticospinal, cortico-brainstem, and corticopontine tracts. Second, the postural and girdle muscle activity through the PPN, the pedunculopontine nucleus, and the reticulospinal tracts. And third, walking through the MLR, the midbrain locomotor region, and the reticulospinal pathways. These pathways can be active at the same time. A person can be walking, keeping upright posture, and voluntarily waving all at once. Now let's turn to pathology. Basal ganglia disorders range from hypokinetic disorders, meaning too little movement, to hyperkinetic disorders, meaning excessive movement. The specific abnormal movements depend on where the dysfunction lies within the basal ganglia pathways and also on involvement of the PPN. The most common basal ganglia motor disorder is Parkinson's disease, and it is primarily hypokinetic. Parkinson's disease affects both voluntary and automatic movement, and there are two common subtypes. We have postural instability gait difficulty, or PIGD, which also can be called the akinetic rigid type. And then we also have tremor dominant Parkinson's disease. So roughly the akinetic rigid subtype, or PIGD, accounts for about half of Parkinson's cases, while the tremor dominant for about 40%, and then a mixed presentation for about 10% of cases. So in PIGD Parkinson's disease, remember that stands for postural instability gait difficulty. Common features include muscular rigidity, a drooping posture, rhythmic resting tremor, and a mask-like facial expression. People often have difficulty rising from sitting, and their gait may show like a flexed posture, shuffling steps, and then a decreased or absent arm swing. So you can often easily observe this when someone has PIGD Parkinson's disease. You can just observe their gait, and then you see that lack of an arm swing. You see that they're shuffling, and you can see their flexed posture. The distinctive signs include akinesia, which means lack of movement, hypokinesia, which would mean like a decreased movement, and bradykinesia, which means slow movement. So overall, you're just seeing kind of less movement than you would expect in someone with this type of Parkinson's disease. You also would observe rigidity, postural unsteadiness, arresting tremor, freezing during movement, as well as visual perceptual impairments, and then this mask-like face and some other non-motor signs. So akinesia, going back to that term, akinesia refers to difficulty initiating movement. Hypokinesia means reduced amplitude of movement, and bradykinesia means slowed movement. Rigidity is that increased resistance to passive movement, but remember it's distinctly different from spasticity because it's not velocity dependent. Postural instability is impaired balance and difficulty maintaining upright control. And then freezing, which I mentioned, is when movement abruptly stops despite the intention to keep going. A classic example of freezing of gait in Parkinson's disease is when someone is trying to walk through a doorway. That new visual cue of a change in the floor or in their environment can cause an episode of freezing to occur. Resting tremor is interesting because Parkinson's disease is primarily hypokinetic, yet it often has this one hyperkinetic sign of a resting tremor. PIGD, Parkinson's disease, also has important non motor features, and these include psychosis, autonomic dysfunction, which actually can be very debilitating, and Parkinson's dementia. Unlike Alzheimer's dementia, Parkinson's dementia tends to affect planning, maintaining goal direction, and decision making more than memory early on. In this PIGD subtype, the incidence of dementia may be very high. Now, in the other type of Parkinson's disease, which is tremor dominant Parkinson's disease, people have both resting and action tremors, but rigidity and slowness are usually milder, and the overall progression tends to be slower than in PIGD. These subtype differences are thought to reflect damage in different regions of the substantia nigra. A classic physical exam finding in Parkinson's disease is something called cogwheel rigidity. During passive movement, resistance seems to catch and release repeatedly, like a lever moving through the teeth of a cogwheel. And that pattern reflects the combination of rigidity and also that tremor. So, what's happening pathologically here? Well, Parkinson's disease involves death of dopamine producing cells in the substantia nigra and also death of acetylcholine producing cells in the pedunculopontine nucleus. Now, importantly, this cell death begins long before the clinical signs become obvious. With less dopamine reaching the putamen, activity in that go pathway decreases. And at the same time, the no go pathway becomes functionally overexpressed through altered activity in the external globus pallidus and the subthalamic nucleus. The combined result then is excessive activity of the internal globus pallidus. That overactive internal globus pallidus then excessively inhibits the motor thalamus, the PPN, and the midbrain locomotor region. Excess inhibition of the motor thalamus leads to underactivity of motor cortical areas, and this then produces that bradykinesia and hypokinesia. Excess inhibition of the PPN combined with loss of the PPN cells contributes to overactivity in the reticulospinal pathways to the postural and girdle muscles, and this produces that rigidity. Excess inhibition of the midbrain locomotor region reduces facilitation of something called a stepping pattern generator, which contributes to gait. Our slides in our textbook also go into detail describing festinating gait, which is really that shuffling gait pattern, which looks like short steps with kind of an unwanted acceleration. So treatment for Parkinson's disease can be medical, surgical, or it can be rehabilitative. Medication that replaces dopamine is usually effective first, but over time, side effects such as hallucinations, delusions, psychosis, and dyskinesia, along with progression of disease into other neurotransmitter systems, can limit how well medication works for Parkinson's disease. Then we have surgical treatments, and these may be invasive treatments that include deep brain stimulation, neuronal transplantation, and also destructive surgery. Rehabilitation is going to be really key here for people with Parkinson's disease. PT and OT can improve mobility and functional status. And there's actually evidence that shows intense resistance training can produce greater muscle hypertrophy and functional gains compared to standard exercise. So you may see this. It's actually kind of a hot topic right now in things like social media. Intense resistance training and kind of more intense rehab may show increased functional gain compared to standard exercise. But in OT, we're thinking a lot about forward thinking with Parkinson's disease, knowing that it's often progressive. We're looking at adaptation, training, and compensatory techniques, as well as preserving, establishing, and restoring function in all the areas that we can. So not every patient with Parkinsonian features, you might see that word a lot, Parkinsonian features, has idiopathic Parkinson's disease. So let's talk about atypical and secondary Parkinsonism. Atypical Parkinsonism refers to primary neurodegenerative diseases, meaning idiopathic or genetic disorders that resemble Parkinson's disease but are not true Parkinson's disease. Red flags suggesting something other than idiopathic Parkinson's include early postural instability, a rapid progression, respiratory dysfunction, abnormal postures, uncontrollable, inappropriate laughing or crying, and signs involving the cerebellum, corticospinal tract, or voluntary gaze. So the major examples that are listed as non-idiopathic Parkinson's disorders are progressive supranuclear palsy, otherwise known as PSP, dementia with Lewy bodies, and then something called multiple system atrophy. All of these can present with features of Parkinson's, but not truly be Parkinson's disease. And you can tell the difference by looking at the substantia nigra to see if those dopamine producing cells are destroyed or if they're intact. So PSP, progressive supranuclear palsy, is associated with early gait instability, a tendency to fall forward, as well as axial rigidity, freezing of gait, depression, psychosis, rage attacks, and a supranuclear gaze palsy. That's one of the key features of PSP is the supranuclear gaze palsy. Dementia with Lewy bodies causes early generalized cognitive decline, as well as visual hallucinations, and then this Parkinsonism. Multiple system atrophy is a progressive degenerative disease that affects the basal ganglia, cerebellar and autonomic systems, the peripheral nervous system, and the cerebral cortex. In multiple system atrophy, you're going to see a lot of dysautonomia. Secondary Parkinsonism looks similar clinically, but the cause is unknown. Causes can be toxic, infectious, traumatic, or drug-induced. A particularly important example is drug-induced Parkinsonism from medication that are used to treat psychosis or digestive problems. In older adults, this can lead to misdiagnosis and unnecessary treatment for Parkinson's disease. Signs that suggest drug-induced Parkinsonism include a subacute bilateral onset, rapid progression, early postural tremor, and involuntary movements of the face and the mouth. The word describing this group of presentations is tardive dyskinesia, and you may see it as a long-term effect of someone using antipsychotic drugs. Another secondary form discussed in our slides and in our textbook is chronic traumatic encephalopathy, or CTE. CTE can include Parkinsonism, disordered thinking, depression, memory loss, impaired goal-directed behavior, as well as disinhibition. A diagnosis of CTE requires a history of multiple head injuries and accumulation of something called tau protein in the basal ganglia and other regions. Causes include things like physical abuse, epilepsy, war injuries, or more commonly, recently in the media, is in athletes who may have played football and have chronic small concussions. So now let's shift to those hyperkinetic disorders. So now instead of looking at hypokinetic disorders, we're looking at hyperkinetic disorders where we see hyperactive or more movement than expected in these disorders. So our slides in our textbook list Huntington's disease, dystonia, Tourette's disorder, and dyskinetic cerebral palsy as examples of disorders with abnormal involuntary movement. So starting now with Huntington's disease, this is kind of the classic presentation of hyperkinetic disorder. Huntington's disease is an autosomal dominant hereditary disorder that causes degeneration in multiple brain regions, especially the striatum and the cerebral cortex. Classic signs are chorea, which is a word that means it kind of looks like someone is dancing. They're constantly moving, and they almost look like rhythmic in the presentation. We also see dementia as a classic sign of Huntington's disease. So in the brain, atrophy of the caudate leads to enlargement of the lateral ventricles. In the early and middle stages of Huntington's disease, The no-go pathway is underactive because neurons die off, while the go pathway is relatively overactive. That then leads to this excessive inhibition of the internal globus pallidus by the putamen, which means that the motor thalamus is not inhibited enough. As a result, then, movements that should normally be voluntarily controlled can now occur involuntarily. We also have extraneous movements that appear, and ongoing movements become hard to stop. The downstream effect is overactivity of the cerebral cortex, producing hyperkinesis, along with excessive inhibitory output from the PPN, which reduces activity in the reticulospinal tracts to the girdle and postural muscles. That loss of a stable base can make chorea even worse. In Huntington's disease, even pathways that normally help voluntary movement can now end up driving that involuntary movement. Okay, we only have a few more disorders here, and next is dystonia. Dystonia is a group of genetic movement disorders characterized by involuntarily sustained muscle contractions that cause abnormal posture, twisting, and repetitive movements. Symptoms often worsen with activity and emotional stress, and they disappear during sleep. Tremor is common in dystonia. Generalized dystonia is often progressive and can affect the limbs, the neck, and the trunk. Medications that affect acetylcholine, GABA, and dopamine may help in some cases. Focal dystonia is more localized. In our textbook, the mechanism is described as an overactive GO pathway due to upregulation of the D1 receptors and an underactive no-go pathway due to a downregulation of the D2 receptors. There's also somatotopic degradation in the somatosensory cortex and the somatosensory thalamus, which contributes to loss of selective motor control. Focal dystonia is usually non-progressive, and OT and PT can be effective. It's not a psychogenetic disorder. That's important to note here because it often can be looked at as such. So two specific examples matter here. Sustained involuntary contraction of the hand is focal hand dystonia. Spasmodic torticollis or cervical dystonia, on the other hand, involves involuntary contraction of the neck muscles, causing abnormal head posture. And clinically, this also helps explain why simple stretching is usually not an effective standalone fix for that dystonic cramping. The core problem is abnormal motor drive and disordered sensory motor control, not just a shortened muscle that needs to be lengthened. Moving on to Tourette's disorder, which causes vocal and motor tics. And these are abrupt, repetitive, stereotyped movements or sounds. Many people feel nearly irresistible sensory urges before the tic occurs. Stress, emotional excitement, and fatigue can make the tics worse, and they can be voluntarily suppressed for a while, but the urge does build up during suppression. Onset of this disorder is during childhood. And remember, this all comes back to disorder of those basal ganglia circuits. Finally, we have dyskinetic cerebral palsy, which involves abnormal involuntary movements called choreoathetosis. This, along with abnormal muscle tone and posture, characterize the disease. Lesions in this disorder often involve both the basal ganglia and the ventrolateral thalamus. Okay, so to put this all together now, the basal ganglia are a group of interconnected nuclei that are located mainly in the cerebrum and the midbrain. They help to predict consequences, select desired actions, suppress unwanted ones, and shape movement through complex loops that involve the cortex, the thalamus, the PPN, and the MLR. When the balance of inhibition and disinhibition is disrupted, the result can be too little movement, as in Parkinson's disease, or too much movement, as in Huntington's disease and dystonia. And beyond movement, the basal ganglia also contribute to goal-directed behavior, social behavior, emotion, motivation, and oculomotor control. That's why basal ganglia pathology never stays neatly confined to one symptom. It changes how people move, but it can also affect how they think, feel, decide, and interact with the world. Okay, that was a long one. Good job. Thanks for listening. Bye.